variable coding quality. So again, those areas that have historically been largely underfunded, guess what, their coding is not that good either. So we've done a clinical coding adjustment. What it allowed us to do is then effectively create a proxy of relative patient need. As I said, we adjusted that further for turnover, so those areas where you've got high student population, so university general practices, high turnover, you're having lots of first, effectively, contacts with primary care. Also, those with communication issues, so where English isn't the first language, it adds a proxy in that for need. We then, in order to get around the lawyers effectively, we added an apportionment for a core staff component. So regardless of size of your practice, you would need there's a fixed level of funding that you'll need. We also added in that rurality, and we added deprivation index. So as much as we've got index of deprivation, we worked with the national teams, we worked with think tanks. No one could come up with a percentage for deprivation. They sort of said the closest we got them to nail down was 5 to 15%. So, you know, those of us in the room, that's not very good nailing down. I'm sure if I went to my board and told them my forecast was going to be right between 5 and 15%, they'd probably ask for a new person to come and present. So, yeah, we settled on 10%. In the fact that it's our own patient data, we could then test it and see whether that was right in terms of a deprivation component. The final thing, and the reason, if any of you have done any negotiating with primary care, it's like herding cats. I probably have easier conversations with a 7-year-old. So in the nicest possible way, it's practically impossible to get them to vote for anything where they don't personally benefit from it. So in order to do this, we didn't do it as a redistribution model. And maybe that's why nationally they're not taking the step, because you need to find the funding from somewhere. We did it as effectively an investment, a leveling up process. So when we did the calculation on the 133 practices, there were some that should have lost money because they were effectively overpaid based on their patient need. We brought them back up to the level that they would have always got and applied inflation. So effectively, they had no reason not to vote this through, so to benefit the other practices. In terms of how do we make it work? It's NHS big data. So we took as much data as we could from everywhere that we possibly could. We anonymised it, but we took it as well, which the other thing where it's a benefit for primary care, we took it at diagnostic and patient level, not the detailed coding level. It's a system that can handle case mix and effectively a full range of conditions. So what we've built in there is the comorbidity aspect. It's got a way of adjusting for coding variation. So again, it doesn't penalise practices that have historically not been good in terms of their coding. As I say, one of the things that was critical to getting all 133 practices to agree that it was a good thing was we did it as a levelling up or a no-losers approach. Try and stand in front of an LMC as a finance director and telling them there's a no-losers approach. They don't believe you. So that took a lot of, that probably out of all of it took the most convincing that I wasn't lying when I said it was a no-losers approach. I never knew that my job title meant that most people thought we were liars. The final one is, it took a bit of bravery. It took bravery from the board. It took bravery from people that were involved to move away from a national payment model that's been in place for 19 years. It also took a bit of beg for forgiveness rather than ask for permission. When NHS England spoke to me about this and said, how did you make it work? Who did you ask for permission? I said, I didn't. So, and maybe that's why it got through. But like I say, because we'd kept that levelling up, we didn't actually affect the GMS core contract. We'd have probably been in courts, I imagine, if we'd done something like that. So what does it actually mean on the ground? This is a tale of two practices. On their profile, they look pretty similar. In terms of deprivation score, they're the same. In terms of funding per head, they're almost identical. In terms of the patient evaluation score, practice B massively outscores practice A. So patients are voting with their feet, they're voting on the feedback, they'd much prefer to be at practice B. In terms of when we then did the relative need and patient need, the differences between what looked like two identical practices was really stark. One of them should be paid in the region of £115 a head versus their £104, and one of them should have probably got just under £100. So the old versus the new, as you can see, practice A, because we committed to that no losers approach, got exactly the same money, but practice B ended up per head of population with almost £20 more than they were getting before. What were the outcomes that we looked at on the back of all of it? Actually, there were some 29 practices, so 22% of all practices, that had over a 10% shortfall or excess target to funding. 8 practices, so 6% of all practices, had over a 15% shortfall to funding. The practices, and every single one of them that had a shortfall, were in our most deprived areas. What does that mean? Effectively, that the Cahill formula, when compared to the LLR model, could be considered to be widening those health inequalities and creating larger gaps every year that we stick with that model. What we now have, which is really good from a population health perspective, is a baseline of patient need. We've got current outcome measures and then a financial baseline as well that we can use to measure progress going forward. So we've got an ability to track whether the change in funding has a change in outcomes and a change in population health and the health of those practices in the ones where it changed. These outcomes are going to be measured over time, but we recognise this isn't going to be something that you're going to be able to determine after a year. This is going to be a longer term outcome measurement. The first annual review is just underway. In terms of areas of increased funding, there's some really good examples that have come out of it. So we've got one particular practice in an area of Leicester where they've employed Bangladeshi-speaking nurses to do all their screening programs, and their screening programs have gone from 33% for cancer screening up to 72% in less than a year. It's based on our data, so we can review it on a regular basis. We do 3-month reviews, or we did 3-month reviews, and we do an annual process where we will change and change those funding formulas. So where patients are choosing to vote with their feet, it's reflected. So there's an incentive for practices to attract patients and to treat them well, to get better patient scores, because the funding will follow. I've particularly rushed through it because it's, at the end of the day, I think the things that I would say for Leicestershire, 1.1 million population, kind of a £2 billion spend, all of this costs £3 million. And I'm sure when you're looking at what you do with growth and everything else, £3 million can probably be spent in a day, I imagine, in a big acute trust. £3 million for this patient population is massively reducing the health inequalities. I was at a health scrutiny committee when I used to be in an acute trust. You didn't have to do any of those things. Went to a health scrutiny committee and realised that members are harder to negotiate with than primary care colleagues. And I thought I was there for 15 minutes. I was there for 95, so that was also a big difference. One of the things that I took along a GP colleague to talk about primary care and the primary care recovery plan and primary care access. And he pointed out to them when they talked about, what are you doing about this? All our patients hate primary care. Actually, we've seen, some 8% increases in appointments in the last year. He did point out that, and you saw it on there, the per head of population funding. That's the funding that primary care get for a whole year, that £104 or £110. The movement from 104 to 120 made such a massive difference for that practice. It costs you more than £104 to insure a gerbil, apparently. So what we're spending in primary care is less than you would insure a pet for. And we're expecting them to treat our population, and they have 80% of NHS contacts on that kind of funding. So when looking at doing things in terms of growth, new funding, particularly the health inequalities money that comes through, I see lots of pilots and lots of things where we think that we can do it. You can make a fundamental change by getting patient data and using that to change the funding model. And guess what? You're not going to get in trouble for it. We've managed to do it. Frimley Health have picked up on the back of us, and we're talking to other ICBs. We'll be doing it very soon in Cambridgeshire Peterborough. But that's how simple it was. In terms of timeframes, I started the discussion and led the kind of task and finish group in October 2020. What year were we? October 2020. And we went live in July 2021. So it was about 7-8 months from start to finish. Any questions? Emma and I rushed in, so I haven't seen Slido or anything. Sorry, we've built the HFMA board.
Yeah, I think we've got Spencer, the question down the front. There's a microphone coming. Hold on a sec. Okay. Oh, just behind you there.
Thank you. Thank you for the presentation. I learned a lot. I'm in secondary care, so I didn't know a lot of that stuff. My question really is, I can see that putting the money in is the right thing to do from the analysis that you kind of put forward there. How do you ensure that putting the money in is the same as getting better care out? Because in my experience, sometimes money goes in and doesn't make a lot of difference.
So that's probably caused the biggest discussion at our board at the time, because effectively primary care is private. It's private healthcare, isn't it? It's, we pay 133 private businesses to deliver healthcare contracts. So there's no guarantee. It's a high trust, low bureaucracy model. The benefit also that I didn't put on here, and probably should have done to a whole load of finance colleagues, is on average to use Car Hill and the many different funding that comes through on primary care. It's about 126 different transactions per practice. Now we've moved to the one funding formula, it's one. So there are some massive benefits in terms of when you're all looking at, running cost reductions. There's one straight away into that terms. It is honestly a high trust. The best thing that we're able to do is we're able to baseline. So we know exactly where all of those practices started from, and we know what investment that we've made. So over time, we'll be able to correlate whether the investment was there or not. The conversation that I had with the board at the time, and it's obviously a system board, was we've spent 3 million on worse without any ROIs. And this is potentially impacting your whole population.
Brilliant.
Nicci, I support what you've done. We've done something quite similar, actually. We called ours the universal offer. And it was about the same sort of maths, actually. It's the right thing to do. I'm a bit more cynical about the benefits, though. I mean, as you said at the end there, the practices aren't incentivised to do the right thing. They do the right thing because they're doctors. They want the right thing for their patients, but they aren't incentivised financially for that. So the easiest thing for a GP to do is just send the patient financially, just send the patient straight off to A&E, let everyone else deal with it. They don't do that because they're clinicians, but I'm saying it is open to that abuse, isn't it? And so I think it's the right thing to do. I think it's a starting point. You have to reflect the impact of deprivation. But don't you think we need to go a step further to really integrate GPs into the whole care pathway? I mean, that's where it's kind of breaking down for me, is that we talk about out of hospital, we talk about left shift, but we then just sort of talk about it, and then we suddenly expect GPs and others to do stuff to patients in the community. We don't actually pay them because we pay them a lump sum that would by a gerbil, as you said. So isn't that the thing? The next thing we need to do, I think yours is this is the first step. Isn't the next thing to find a way of incentivising GPs to be part of the whole pathway?
Yes, so I think there's a couple of things in that, Paul. Firstly, to get them around the table, we've got to make sure that we're funding them fairly for the population that they're expected to serve. And actually, it particularly helped us in being able to, in Leicester, we're able to put R&R on the GP salaries. So actually people would want to work there, whereas before they wouldn't, because of just it's a tough population, the sheer volume and numbers. So there are many, many benefits that come from getting the funding right and levelling it up and matching it to patient need. In terms of next steps for primary care, you're absolutely right. It's got to be that primary secondary care link rather than a handoff, which is what I think it is at the minute, and it's probably a hospital pass, isn't it, in sports terms. But I also think that we've had a lot of it through today, the digital and tech side of it. If you look at primary care, it's probably similar to the funding model. It's exactly the same as it was 15, 20, 30 years ago. Hospitals have moved into that digital space and primary care really haven't. So I think that we create capacity and we create space through the digital and tech, which allows then that integration up to secondary care to do more of that pathway-based care, which we need them to do. Incentivising them has got to be the key thing, because actually, like I said, I think someone said it today, £2 per head of population for a primary care recovery plan just not going to cut it. And actually, if you're a GP, what are you going to do? I actually asked a room of strategic GPs in Cambridgeshire and Peterborough, how could we stop the 8 a.m. rush? And they said, start answering the phones at 9. So for £2 a head, that's what I'll do, which was really unhelpful. But I think a lot of it is in terms of that, it's that digital tech. But yes, if we're doing incentivisation for every other waiting list and we're not treating primary care in the same space, well, why do you expect them to come to the table and do more?
Any more questions for Nicci? Oh, David at the back there.
Yeah, thanks, Emma. Thank you for your presentation, Nicci. Oh, sure. David Chandler, Director of Finance at North East North Cumbria ICB. So thank you for your presentation. You know I'm a big fan, so you probably get an easier question or two. So on the trust side of things, you know, I do reflect that we work in a similar space, don't we, on personal health budgets, and you know the measurable outcomes seem to be better than, you know, take account of the fact there is some risk in that, but the outcomes are worth that risk, and I think this is probably the same. So I just had one main question. Well, I had two. I'm getting over. I can't remember what the second one was now. But I was going to ask you about outcomes in terms of impact on secondary care and mental health. In terms of, is it too early, or are you starting to track for those practices that have like leveled up? Are you starting to see, or you're monitoring the impact on, say, A&E attendances or urgent care needs in mental health and the like? Because I would expect to see benefits in that area. My other comment was just going to be, I think, so I can't remember the question, but I thought another comment was, you know, I think it is the right thing to trust GPs, because I think the vast majority of them do want to do the right thing for their patients. And I think we do need to bear that in mind, that 99% do. There's always going to be the one, you know, but we can manage that, I think. I think the benefits outweigh the risks. So main question was the impact on secondary care, monitoring that.
Yeah, and hopefully by the time I start talking, I won't forget the second one. It's at the end of the day. David, you're right. The terms of what we're starting to look at is all of those secondary care metrics. So where are we, not just primary care, so the outcomes aren't just, you know, has access improved, are you know, some of your metrics around screening and things like that, but what we saw, particularly in the practice that talked about where their screening rates went up, their stage that cancers are diagnosed has come down. So they're seeing more cancer diagnoses at stage 1 and stage 2 rather than in stage 3 and stage 4, which surely in terms of cost and overall impact on the health system is going to be huge. In terms of going through to A&E, things like that, we're seeing a change in some of the university practices because students were just not bothered if they couldn't get the GP on the phone the first time they just go to A&E. So what we found actually is that younger demographic, as we've put more funding into that and they've developed things like apps and other stuff, some of those kind of more forward-thinking practices, then we are seeing it. But yeah, I'd really hope that we'll be able to study the outcomes over time and see where the impact's being felt. In terms of the trust thing, I think we've just got to trust that 99% of people work in the NHS for good reason. And we seem to be able to do it with everyone else, but with GPs and potentially with some consultants, we have this lack of trust. My experience of the 133 practices in Leicester, there's maybe 5 or 6 that probably took it to their pocket and paid partner salaries on it. Actually, the rest of them came up with some really good initiatives and were genuinely wanted to pay staff, so their staff, and to be able to forward project and look at how they could potentially change their services. And some of them, like I say, it was to be honest, that they were just really glad that someone had listened, because they'd been screaming that their population was ill-funded for the service that they needed to provide. Go on, David.
Just takes a bit longer these days. I'll refrain from any further jokes. What I was going to say was, we were just talking the other day before, weren't we, about dental? And I'm just wondering if there are any things bubbling around in your mind now about what you've done in primary care in the GP space in terms of, are there any opportunities there on the dental side of things? Because, you know, like, you can get dental wastelands in some deprived areas, etc. And I suspect it might well be linked to the finances in the same way in primary care is challenging. So I just wondered if you have any thoughts in that area.
Yes, so David and I weren't just discussing our own teeth earlier. We were talking about dental services that have just moved into ICB responsibility. In terms of dental, so for those, again, just a very please, apologies if you already know, the dental contract was changed in about 2016. It was changed because we were over-treating patients. So they deemed that we were putting too many fill-ins in kids' mouths, or we were effectively over-treating patients. So they moved to a block contract, and now we have a barren land of NHS dentists. So it's one area where I think massively the payment model could completely change the face of a service. So when you look at it, when we've looked in Cambridgeshire and Peterborough in terms of capacity, we've got quite a lot of dentists actually. We've got very few that are offering NHS services. Because if you go to an NHS dentist right now, there are tiered programs. If you go in with perfect teeth, just need a checkup every 2 years as an adult, you'll get paid the same as someone that has to go every 3 months and has fill-ins. So which person are they going to choose? In terms of, I think it's probably the same again for all the other systems. The number one procedure for under fives is tooth extraction. So how do we get that funding at the right level? And dental isn't a lack of funding. The funding is there. We give millions of it back every single year. It's just that the contract is so restrictive. So again, I might be doing the begging for forgiveness, but my region and the national bosses are sat in here. So I suggest there's something to look at in terms of contracting for dental.
Brilliant, thanks, Nicci. Any more questions? No, I think we will wrap it up then. Just to say that the HFMA is working with Nicci to write this up into a detailed case study, which will be available at some time over the summer. So do keep your eyes open for that. And I just want to say thank you very much to Nicci for that fascinating presentation.
So, I'm just here really to tell you what happens next, but to most importantly say a massive thank you to our speakers today. It's the first time we've done this, the first One NHS Finance Leadership Summit we've had of this sort. And when we set up One NHS Finance, it was about doing things for the NHS by the NHS. It was about innovation. It was about sharing our good ideas. And I think we demonstrated that today, haven't we? I'm hoping there is something that you've taken away, probably more than one thing you've taken away today, thinking actually that's really interesting, that could really do something where I am with that. So thank you to everyone that spoke. And we started with Julian, who said how much we've achieved in the last year, even though it feels really challenging at the moment. Next year will be really challenging. We've achieved a massive amount, and One NHS Finance has been a massively important part of that, and focused particularly on a productivity challenge. We then had Measuring Healthcare with Rebecca and Nick from North Staffs, who talked us through how we can actually work together to be more flexible in services we provide at a lower cost with better outcomes. And again, that real theme of productivity by understanding the data and linking up finance with our colleagues, how we can change the way we deliver services. And Jenny launching the EVO framework, which I think is going to be increasingly important going forward as we iterate it. And please talk to the team about the EVO framework. We talked about innovation in finance. So Adrian with Charlotte and Loie from East Lancs and Ed from MFT. Some fantastic stuff going on within finance teams making a difference. So that shared approach to system innovation and costing and what you can do when you put all of that data together and kind of understand what's going on in your system. Again, costing a real theme there. and in Manchester, not only the potential of RPA now, but actually RPA's here now, isn't it? And actually we should be using it. And again, the productivity we can get from that, but also how we can release our staff's time to do things, frankly, that are more interesting but add better value. We had the session on developing and supporting people with Joanna, Simon, Suzanne, Hardev, and I guess reminding ourselves that the network we've got here today and the wider network we've got is the envy of the other professions. HR colleagues in particular always talked about they wish they had something like this, and you wonder, well, why can't you? But actually, we are incredibly lucky, aren't we, to have the network we have. And of course, it's not luck, it's the hard work from tens, hundreds, thousands of people in our teams that pull all of that together. We talked about how we're leading the way, but there's a lot more to do, and how actually we've got a real collaboration of the willing here, but we need to go further, don't we? Had a great session from North East London on the difference you can make across an ICS and to a population, and how, again, finance, costing, and professions coming together can make a real difference, get real insight into a population and what we can do differently in order to get better outcomes and facilitate those improvements in the system. And then fantastic at the end, Nicci and Emma on improving health inequalities through integrated care. There's something in there, isn't there, about, you talked about data and finance model, but actually how relatively small amounts of money can make massive changes, and how our profession bringing that data and a different financial model together can make that real difference on the ground. And I'll make no comments about asking permission or otherwise. I think this is a safe space, isn't it, hopefully. So, fantastic day today. I hope you all agree. In terms of what happens next, dinner is at 7 o'clock. It's at the Library of Birmingham. It's about a 10-minute walk away for those that are going to dinner. I think there is a group going about 6:45. So if you'd like to be in the pack and not have to worry about how you get there and what the directions are, Emma, I think you, Marky, and others will be downstairs at 1:45 if we want to go over together. In terms of tomorrow, look forward to seeing you back here in this room. We start at 8 o'clock. Focusing on IT and AI to start off with, so 8 o'clock, nice and early to start off tomorrow's sessions. Please continue to visit the stalls next door, and if you can continue to get your stamps on your card, and we'll have the lucky winner of that tomorrow. So thank you for your engagement, thank you for your attention. I think it's been a brilliant day. So again, thank you for all the speakers today. And the one last thing, we were going to have a bit of a conversation about planning in here now. I'm suggesting we don't do that now, but I'm very happy to talk about any subjects downstairs if anyone would like to do that over a drink. So thank you all. Thank you for those online. Thank you in the room, and see you tomorrow.